Just let me know and we'll figure out something, you know, for anybody who would have trouble that morning at 8. Because you get an hour and a half. Yay. Leah, yay. And Chris. What is the defect in Bernard Soulier? What's the defect in Glanzman? And what is the defect in VWF? So Bernard Soulier first is that they were intrinsic platelet disorders. So what does that mean? It means a platelet is no. These are platelet function disorders. So we're going to get into platelet number disorders after we do storage pool. But these, a bleeding time can be affected if you have very low platelets, like someone on chemo that bottoms out to like 5,000 to 10,000. They're going to have an abnormal bleeding time because they don't have enough platelets to function. So these are, something is missing that they don't do their job properly when they're platelet function disorders. So the two of them were intrinsic, one was an extrinsic defect.
The Bernard Soulier and Glanzman, who's missing the glycoprotein 2.
What was Bernard Soulier missing?
Glycoprotein 1B.
1B.
And Glans was glycoprotein 2 and 2A.
2B and 3A was Glanzman's. So that means the platelet was defective. That's why it's intrinsic. So then what's VWF missing? VWF. But that's not part of the platelet, but it's something that affects platelet function. So that is an extrinsic problem. What was the common test that was abnormal or elevated? What assesses platelet function that we did in our first lab?
Bleeding time.
Bleeding time. If you didn't have a bleeding time at your lab, they would do a PFA 100 analyzer and it would be an abnormal test. What bleeding, if these are primary hemostasis disorders, what bleeding symptoms should you have?
Superficial.
So superficial, things like petechia, purpura. Remember what ecchymosis was? That can be in both platelet or clotting factor disorders. How big are they usually? Greater than, remember?
3 centimeters.
I think it says 1 centimeter in the book, but they're larger reddish bruises. But it's not something you use to distinguish them because it can be in both. And what sets Bernard Soulier apart? You're the tech. What would you see on your lab results? Because sometimes that's all you know because you don't get any history. What would set Bernard Soulier apart? So on your CBC differential, the platelets would be large. And then on the CBC, the platelet count would be decreased, less than 150,000. Okay, so that sets it apart. Do you remember what the test is you go to when you truly have an abnormal bleeding time and you're not on aspirin? What is the test they go to next? You can actually, you spin the blue top slower, remove the plasma that has the platelets, and then you add stuff to make the platelets. Platelet aggregation studies. What is abnormal with 2 of them, of the 3 diseases? Which aggregator? Because it doesn't need glycoprotein 2B and 3A. It needs VWF and glycoprotein 1B when you use this aggregator. Ristocetin, the antibiotic. So Bernard Soulier and VWF are abnormal for ristocetin. And so what is different about glands? How are they all inherited first? Who can give it to you? Autosomal, okay. meaning both parents have to give a defective gene, but it can affect a girl or a boy, it doesn't matter. It's not sex-linked, where usually the mom passes it to their son. Glandsman is missing what, as we said? 2B and 3A. Tell me what, we know everyone has an elevated bleeding time. Tell me what is different than when you do the aggregation studies for Glandsmans. Well, you'll use it.
It won't be abnormal.
It'll be normal. But every other aggregator will be abnormal because they need 2B and 3A. And we'll learn that when we get to the platelet function test. I even make you have the curves, and I'll teach you about a monophasic and a biphasic curve. And there is a lot of aggregators: thrombin, epinephrine, collagen, optimal ADP. All of them are abnormal when you have GT, Glanzmann's thrombasthenia, except ristocetin would be normal. And then what sets von Willebrand's apart? It is unique because it does something with factor VIII. Remember what it does with factor VIII?
Protects it or something?
Protects it and carries it to the site. So I am not going to make you, know the factor VIII. This will be something that you'll use for clotting factors, but I put the factor VIII molecule on the back side of this. You don't have to know it for the test other than it's a protector and carrier, but I wanted you, this will be something that goes with the clotting factor deficiencies, but since we're kind of on it, I want you to see. You don't have to know this chart on the back side with factor VIII for the test, but I think if you understand stuff, and Chris, if you have an extra one, pass it across to Jen. Just keep it on the factor VIII molecule a minute. Hopefully we have a couple extra. You passed over. Is that the one? Is there? Hopefully I have my original then. Okay, look at this a minute, because remember what I said. I think you're smarter if you understand what you're talking about instead of memorizing just for the sake of memorizing. But factor VIII, von Willebrand is a very important molecule, and that's one of your more common deficiencies. So, probably what for sure we will get to for clotting factor deficiencies, we're going to distinguish factor VIII, factor IX, and von Willebrand's as they affect clotting factors. So if you understand your von Willebrand's molecule, you'll understand its role when we compare those three. So you're going to have probably 6 comparisons on your test. So factor VIII, they call it factor VIIIC, is the smaller subunit of the whole factor VIII complex. So these are all the different tests you can do. The doctor can order factor VIIIC. Sometimes you'll hear it termed as antihemophilic factor. So depending on your specialty labs, they might do more tests naturally than any other regular lab, because a regular lab doesn't do but probably a factor I or fibrinogen factor assay. But it is the smaller subunit of the factor VIII complex. The VWF is the major protein, and there's different tests they can do. They can do a ristocetin cofactor, they can do the von Willebrand antigen. These are the different names they call it. But what it does is it stabilizes HC when bound to VW8 during circulation and function in prevention or protection of HC. So I think, I'm a big fan if you understand what's happening. Don't just memorize for the sake of memorizing. So what test is unique that's elevated then with VWF disease? What else is elevated besides the bleeding time then because of its job here? PTT. So if you can't get 8 to the site and you can't protect it, and remember it's a labile factor, it's going to be degraded already easily. Your PTT is something that sets it apart. So if we get through VWF factor 8 and factor 9, your case studies are including VWF factor 8, factor 9, BS, GT, and where most students mess up, they won't see on VWF that it's a female patient. And they won't pay attention that there's an elevated bleeding time. They'll see an elevated PTT and say, oh, I bet that's hemophilia A. You got to look at the whole picture on the case studies. So remember, a von Willebrand still has more superficial bleeding because the VWF piece missing for platelet adhesion is the biggest issue. But it will affect your PTT the more deficient you have. The larger the deficiency or the worse the deficiency of VWF, it's ultimately not going to help factor 8, and 8 won't be able to do its job in the PTT. Okay? One other thing I told you, so I'm not testing you on this, and our new books don't even have this in it. I had to go back to the Harmoning Old Edition again. But I think you need to understand what you're doing. So sometimes the newer books leave out pieces that I think help you understand the disease states better. I told you there were multiple. The top handout of this one is really good for the distinguishing type 1 von Willebrand's, factor 8 and factor 9, which we'll get to. But I wanted to have you see how many different types of von Willebrand's disease there are. You don't have to know, we're concentrating on von Willebrand's type 1, but I still feel you need to see that there are 5 different types of von Willebrand's besides acquired. The only thing that the top chart will help you. So the top chart, I would put test 3 because that's my goal to get through that today. The bottom chart is just for your information. But sometimes, there's things about the new books I like, and there's things that I feel they leave out that I think helps your understanding better. So table 32.3 is good for test 3, but put NA down by the von Willebrand's. I just wanted you to see there are 5 types of von Willebrand's. We're just concentrating on type 1. So you can circle type 1 if you want to, the very first one. But these are just things I think make you understand. This is a really neat handout that we probably won't get to a lot of it today. It'll be on test 4. This is a great handout on all your clotting factors in one little sheet. It is great. Instead of reading 20 pages on each one individually, they have it in one little sheet. So this will be very good for test 4. So if you want to put test 4 on this, so that's what our game plan is. Our game plan is to take test 3 Thursday. So tomorrow our focus will be to finish up what you missed getting done last week's lab. Then we'll review the test 2 first thing. We'll finish up what we're going to get, we need to repeat. Or if you got everything done, then you can just practice. We want to make sure everybody who didn't get the fibrinogens done have to get them done. Okay? And then we'll review for test 3 at the end of lab. On Thursday, what I'm going to do is have lab set up. So as soon as someone's done with the test, they can go start reviewing. So then we won't waste any time. People can get done, go work, and it will free up some of the machines depending on slower test takers versus fast test takers. So our game plan then next week will just be strictly lecture on Tuesday, and then we'll practice and get the lab practical done on Thursday. So what I would like this week, those of you, I kept the bloods of people who were done drawing to try to get everybody done with the blood drawing part this week, because that way that's one less thing you have to worry about next week for the practical, the blue top and the purple top. Okay, so where we left off on this PowerPoint for our storage pool. You already know something that affects storage pool by your first test. What do you think affects the release of the granules? That's what we're talking about. When you talk about storage pool disorders, you're talking about either you're missing alpha granules, missing dense granules, missing both granules, or you can't release them. You already know something that you won't be able to release your granules. So what affects that? If you, what messes up your cyclooxygenase? So that mimics a storage pool defect. If the physician would not know you're on aspirin and you do your bleeding time, it's elevated, they would see, especially on the PFA 100 test, there's these two cartridges you put in your analyzer. When it's an aspirin defect or a problem, only one is defective. When it's a true problem with your platelets functioning properly, both cartridges are defective as far as how long it takes to clot. But aspirin is probably the biggest reason you're going to have something that mimics a storage pool deficiency, because the granules don't get released. Because you don't make what? What doesn't get made that triggers the release reaction?
PF3.
The TXA2, because it's missing the cyclooxygenase. That is still going to be your biggest storage pool type defect. But normally you're still going to have superficial bleeding. So everything we've discussed so far has had superficial bleeding. Okay? Either mucosal bleeding, petechia purpura. They're going to have prolonged bleeding times and normal platelet counts. So the only the only platelet test so far that we've said had low platelets is which one? Of what we've discussed so far. Bernard-Soulier. Glanzmann's been normal platelet count. Von Willebrand's been normal platelet count. Any storage pool disorder has normal platelet counts. So it's only been Bernard-Soulier, because we haven't started the platelet number problems yet. Okay? So these are just examples. They will not be case studies. The biggest case study potentially would be if I have something with aspirin. But where you're going to see that might be a problem, you're going to know it if they're on that drug, in the blurb about the patient. But there's one called Hermansky-Pudlak. Sometimes in your reading, they'll call dense granules delta. I just don't want you to be confused by that. They're different terms depending on which book you read. There's one called Chediak-Higashi that is also missing the denser delta granules. There's one called Wiskott-Aldrich. It's missing both granules. And then there's one called gray platelet. So if at anything I do a matching, I'm not going to have any kind of case study. These aren't going to be as common as someone on aspirin. So how does the physician rule out? They ask, have you taken any aspirin or any medication with sulfosalicylic acid? And if they haven't, then you got to do more studies to see if potentially they were genetically born without these granules. Okay? So the most common storage pool disorder is going to be if a patient is on aspirin and it mimics, yes?
Is it niacids that have salicylic acid? Is that what they're going to ask for that group?
If the ingredient on the medicine says sulfosalicylic acid, like Tylenol is acetaminophen. I'm not sure off the top of my head what does also have aspirin. I don't know if Excedrin does. I'm trying to think what else. I'm not sure what's in Advil. But the key thing is to look, especially if you're going to have surgery of any kind, you would not want to have any aspirin a week prior to the surgery. Then if you take anything for a headache or a fever or whatever, you want to read the ingredients, because that's the key piece, is the sulfosalicylic acid. That's going to be the most common disease state you see, because it mimics a storage pool disorder, because the granules can't get released. They're there, they just can't get released. These are the true defects in missing granules. But the most common one we'll all encounter in coag is being on aspirin.
So you say you have that on the test that,
It'd be like a matching. It won't be a case study.
okay.
The granules won't be anything with a case study, but aspirin could be a case study. And when we see how far we are, what we're going to do is add to the test 3 worksheet, because I don't know how far we're going to get, so I couldn't put in, because this is your first big one with case studies, and it's just the process isn't always quick to get through them. And so I didn't want to put things down that I didn't know if we'd get to. So we'll add to what our test 3 says on the case studies when we see where we get to. Now these will also just be a matching. They're just examples. Do you remember what were the 3 acquired vessel ones that I had you know? One kind of has to do with the age of the patient, if that helps you to remember. Senile, purpura was a acquired vessel one that sometimes as you get older, the collagen breaks down more easily, and you might see the petechia and purpura. And there was one pair of proteins, and one was vasculitis, where inflammation. So those were just 3 acquired ones. These are acquired platelet ones. So I won't have a case study with them, but you have to know them, either a matching or a question. What would be examples? A big one is aspirin. So I definitely star aspirin, because that will affect your platelet function, and it doesn't mean you have really technically anything wrong with you. Myeloproliferative disorders. They're not really sure of the mechanism, but this will be a big topic in hematology. You might have heard of polycythemia vera. That one, all your cell lines, your red cells, white cells, and platelets overproliferate. Normally your bone marrow knows when to shut off and how much should be put out into circulation, how much should stay put in your bone marrow, and in here it doesn't. One of the treatments for someone who has polycythemia vera is they do a therapeutic phlebotomy. Monthly, you will go in and they'll actually draw a unit of your blood to reduce your number of cells and platelets. And the problem is with that is very hard on your heart to push around that thick of blood. The only person that usually has an 18 to 20 hemoglobin is usually a newborn. They're very, very concentrated red blood cells. Most of us, 12 to 16 for girls, hemoglobin, 13.5 to 18 guys. Well, when you get adults in with 18 to 20 hemoglobins, that, I think of it as sludge, trying to push around your circulation, this thick mass of cells. So one of the treatments is to come in and remove that. Another one we're going to talk about when we talk about increased just platelets is called essential thrombocythemia. These people, something genetic, it triggers them to overproduce platelets. So you have, instead of up to 450,000 in your circulation, you have over 1 million. And that isn't good either, because if they get activated at all, guess what's going to happen? Clotting everywhere. And so these are examples of what could affect platelet function. We already knew multiple myeloma is a paraprotein. When they're not really sure of how it all affects, but it could be an example of both. They feel that the paraproteins coat your platelets. So not only do they affect your vessel, but they also, the coating of these platelets don't let them work properly. So you could use that disease, the paraprotein production with multiple myeloma and macroglobulinemia, as an example of an acquired disease that could affect both your vessel and your platelets. So you could make a little note that it can affect both your vessel and your platelet. Cardiopulmonary bypass is a pretty tricky substance. Not only, I mean, they have to pretty well work for your heart while they're working on the bypass and get a mechanism to pump the blood while they're working on the heart. It can also trigger platelet activation and sometimes shearing of the platelets. One term you're going to learn in hematology when you do RBC morphology is called schistocytes or fragmented red cells. When you get clots, if there's platelet activation by this mechanism of pumping for you while they work on your heart, if you get clots in circulation, sometimes whether it's platelet clumps or if it also encompasses clotting factors like in DIC, as your red cells try to go through circulation, they sometimes shear them off. So you go look at the peripheral smear on your CBC and you'll see it looks like some of the red cells have bites out of them. Instead of being nice kind of ovalish or round ovalish discs with smooth membrane, you'll see like hunks out of it. And that's a big deal as a tech not to miss those. I was in a workshop in Chicago one time and it was all on hematology, and they scared the heck out of you because they said one person died of DIC because the doctor didn't see anything abnormal listed on their RBC morphology. They must have put normochromic normocytic, and this person ended up dying of DIC. And actually when they went back and reviewed the smears, they had fragmented red cells, which some places you call schistocytes. We had a term at St. E's that you could flag on the computer called fragmented red cells. But RBC morphology you don't minimize. It is critical with some conditions, and we're going to talk about two of them, thrombotic thrombocytopenia, and we're going to talk about hemolytic uremic syndrome. And so anytime there's potential clotting in your circulation, those red cells can get sheared off as they're trying to go through. So remember, you want to do the best you can every lab test because someone is basing their treatment and diagnosis off what you turn out. So they have to trust you, what you turn out. So that can be a tough one because you're doing something good for your heart to try to make the blood flow to it, free, but it can also start activating some platelet function. And then uremia, we'll learn in urinalysis in the fall that you have, anybody know from anatomy what your waste products are in kidney function that you're trying to clear?
Urea.
Urea is a big one. Ammonia can, probably urea, uric acid, and creatinine are your three biggest, but anything that cellular metabolism can break off an ammonia group. So we'll talk about when we get to renal function how the ammonium iron is something that is secreted to get rid of excess acid production. But they're bad. If you do not clear your waste products from metabolism, they can interfere with your platelets functioning properly. Because you'll learn in chemistry, so many things start tying in from now on, you guys. Different departments, things you learn, we'll see how it affects another department. We know dialysis patients need to be dialyzed just by a test called the blood urea nitrogen and their creatinine level. That is done in a chemistry panel. We in urinalysis, done with a specific gravity and osmolarity, can look at their urine and know they have waste products building up. So you'll start seeing the connection. So if we had a dialysis patient come in, your BUN should be up to about 20, the value. And we'd have dialysis patients that the BUN would be 95, the creatinine should be around 1. Their creatinine levels would be around 5. You knew they needed dialyzed because the waste products were building up And then the waste products can do damage to other systems. And coag is a big one that can be, won't function properly. So all you need to know, the most there'll be is a matching or a question. These are not case studies, the acquired ones. The only acquired one I have as a major case study when we get there is DIC. That's a biggie, because I think every one of you will encounter a patient that has DIC if you don't see any other coag problem. Okay, so those are examples, and the one that was a common one between vessels and platelets was your paraproteins. Okay, so now that all is function. Now you gotta see how, and most of the chapters I notice start with number problems. But there are key ones through here that will be case studies. So we'll flag them as we get to them. But we probably, between the BS, the GT, the VWF, those three for sure. A storage pool disorder, like aspirin, triggering it, because that's the more common one you'll see out of anything. Those four. Now you're going to have, May-Hedlund you won't have, but ITP, you'll have to know comparison of acute and chronic, and TTP and HUS. So just from platelets, you're going to have at least potential 8 case studies. And we'll probably add factor 8 and factor 9 from clotting factor deficiencies. So the hardest piece that students seem to have trouble remembering are the general causes of why you get low platelets in your circulation. So this is all about number now. So we're looking at disorders that fall below 150,000, because that's our low for our platelet count. And I need you to know 3 general causes of why they're low. The first one, you just may not produce them. And then the example is May-Hedlund, so we'll get into that. The second reason, and this is the big reason, they get destroyed in circulation. One thing I did think was neat, our new book says in TTP they're destroyed because of large VWFs being produced. Our older edition said it was still unsure. So at least this newer edition says they're pretty well determined that this person with TTP produces these large VWFs that trigger taking platelets out of circulation. So they're destroyed once they're in circulation. So if it helps here, they're decreased in the bone marrow. If this helps here, they're normal in the bone marrow but get destroyed in circulation. So you need to distinguish a different reason, okay? This one here is some people have issues, like we had a lady here that died from, her spleen was so enlarged by the time she retired because it was so dangerous, just her walking around, driving, anything. Her spleen stuck out. It was so enlarged, it stuck out one side of her shirt if she had a form-fitted shirt on. And she had a hematology condition involving her platelets. I would draw her blood like once a week and we'd just check it. Her platelet count started reaching 500,000, then 600. By the time she ended up retiring, it was like up to 1 million. And her spleen started sequestering them. And they call it splenomegaly. So some conditions trigger someone's spleen. Your spleen kind of cleans out all your cellular destruction and debris. And in her case, it started taking all her excess platelets and enlarging and getting bigger and bigger. So sometimes people get a lower platelet count due to the spleen grabbing them out of circulation, and then you don't have enough in your circulation. This is going to be our big focus, number 2. So I would definitely star number 2. That's where your case studies are coming from. But you got to know the 3 reasons they decrease. First one, bone marrow doesn't make them. Decrease in the bone marrow. Second one, they're normal in the bone marrow, but they get taken out of circulation for some reason in your circulation. And then the third one, for some reason, maybe due to another condition, your spleen enlarges and removes them out of circulation and they start depleting. What do you test? Venous blood. So you're going to get a lower platelet count. So this will be the big one. Okay?
The second one you say is normal in the bone marrow.
And it gets decreased in the circulation. Something removes it. So this one won't be any case study, so you don't have to put case study by this one, but it's an example. What they see, the low platelet count is the megakaryocyte doesn't mature properly in the bone marrow. And what you see in circulation is large platelets. Once you start getting platelets that look almost like a size of a red cell, which is about 6 to 8 microns, normally they're down like about 2 microns. They're so tiny little purple dots. They're larger platelets and they're low platelet count. And one of the things you'll learn with Diane that kind of signifies bacterial infection. If you get these bluish bodies in your neutrophils, they call them Dolly bodies. They say these patients also have bluish little kind of inclusions in their neutrophils. And that's something you'll talk about with Diane when you get to things that signify maybe an infection with your white cells. A Dolly body, and if you get big vacuoles, do anybody know what cell is commonly vacuolated of your 5 white cells? I don't know if you got to see the white cells when you studied them, but a monocyte commonly has vacuoles. A neutrophil does not. So if you are doing your smear, you're counting your 100 white cells, and you start noticing your white cells have these blue little inclusions in them, especially your neutrophils, and they get big vacuoles, many times that signifies they have a pretty good infection going on. So this person, the megakaryocyte, which becomes the platelet, does not mature properly, and there's fewer, and one of the clues is they're larger in circulation, and they got these little blue Dolly-like bodies in their white cells. Most patients are asymptomatic, so this is an example of a defect in the maturation or the formation in the bone marrow. So think of this as a defect of the bone marrow process, and that won't be a case study. This one will be though. So we're going to do comparison of acute and chronic. So you might get a question like, give me 3 similarities and 3 differences of your acute and chronic ITP. Anybody know what idiopathic means? ITP, and you're going to see it more called ITP, but idiopathic thrombocytopenia purpura. You're going to see it as chronic or acute ITP, okay? Normally, acute is usually children, a lot of times under 5. Normally, these are women. Chronic is more women, probably we'll say 20 to 50. So it's a big difference in their age. Many times acute, usually they say follows a viral infection. And not sure what triggers chronic. They're both going to have superficial bleeding. And they both have low platelet counts. This can fall below 20,000. usually they say this is between 30,000 and 80,000. Sorry if you can't read something, just ask, because I have not great handwriting or printing. A big thing that is common between both of them is the PA-IgG is the antibody. An antibody is formed that removes the platelets from circulation. And the platelet, they usually call it, PA stands for platelet antibody, and you'll learn in serology, when you're discussing the immune system, your first antibody to form when you're trying to fight an infection is IgM. They call it the primary responder. The secondary antibody that forms is called IgG. They call it the anamnestic response. You have more IgG in your circulation than any of the 5. So they call it a PA of the IgG type, and it's in both. So you have already 3 similarities up here, and you have 2 differences. Okay? Ironically, you'd think, oh my gosh, how does that child survive? Do you know what the term self-limiting means? It usually takes care of itself without treatment. The acute one, usually that child recovers on their own within a couple weeks and their platelet count goes back to not normal. I don't know. An immune complex is when you have an antigen and an antibody. So let's say, and I just read a case study when I was looking over my final for the program, and I took a lot of case studies from the review books, and one of them was a child who had just had chickenpox, was the clue, and the child was less than 5, and then they had a platelet count of like 15,000, and then within 3 weeks everything was back to normal. So I thought to myself, it has to be acute ITP because it was following a viral infection and it was self-limiting. The child didn't bleed, so they didn't have to take action and give them treatment. So it's not that they won't treat them. You get down to 20,000 and there's a good chance you could have some bleeding. So it's not that they don't. They just say normally it is self-limiting, so no treatment is needed. So that's your third difference. And this one is, the next one is harder. Okay, so when you go to chronic, even though their platelet count isn't as bad as the ITP, they have more trouble getting rid of the antibody. A lot of times what the antibody does, it'll attack the platelet, and if they can't get cleared, they build up in circulation, and the antibody keeps getting formed, and it keeps taking out more platelets because it finds a platelet, grabs it because it's an antibody to the platelet. These people don't clear them fast enough, and that antibody takes out more platelets. The only case I knew for real wasn't anything with the lab. My sister's friend got a low platelet count. She was probably on prednisone, and not just low doses, because she didn't even want to go out of the house after a few months of treatment because she became almost grotesque looking. Her head was so enlarged, the swelling, it was terrible. And if the prednisone or steroid does not work, then you go remove the spleen. So sometimes the spleen, if you remove it, it can't sequester more platelets out of your circulation. So you have your third difference. You start with a steroid like prednisone, and if that doesn't work, you remove the spleen that keeps removing them out of circulation. And many cases, just doing a splenectomy increases your platelet count for at least a short term. So you are going to have to be able to tell me 3 differences and 3 similarities between acute and chronic, and you got to be able to identify these in a case study. So I would definitely put case study on acute ITP, case study on chronic ITP. And you got to be able to compare them. Okay? So what seems like would be the worst one actually handles itself usually without any treatment at all. And sometimes the viral, they feel in acute, attaches to the platelet, and you see that as foreign and make an antibody. Okay? So what are our 3 differences? The age and who.
Platelet count.
Usually the viral infection, the platelet count can be a difference. Treatment can be a difference. What can be a similarity? The platelet count number could be the difference. What could be similarities? Superficial bleeding, that they have low platelet counts, because they both have low platelet counts, so that the count itself is a difference, but that they have low platelet count is similar. They don't have normal platelet counts, either of them. And the treatment, the antibody form is the big similarity. That's probably your biggest similarity. Both of them have an antibody that is removing platelets from circulation. Okay? So these are probably the acute, well, either of them, acute or chronic, might be the most common platelet disease you encounter in your career, because it seems like someone along the way is going to have a low platelet count, really not sure why. But many times with the children, they feel it follows a viral infection. Now, TTP, it's another case study, so if you want to write that. The big thing, and I remember we had, back in the day, they did these end services, so you had a speaker, everybody called the same site, then the speaker would project into your classroom, you had handouts sent to you, and many hospitals could listen to the same presentation, and we had this. TTP was our presentation back in my training day. You gotta know the 5 symptoms. And this becomes, when we get to DIC, I'm gonna have you compare TTP, HUS, and DIC. So you're gonna even see some of these cross into being close to disease states down the road that we'll encounter. TTP and HUS have little platelet clumps that get into circulation. And remember, on your morphology for your diff, it could have sheared red cells, which are called either fragmented red cells or they're called schistocytes, which you'll get a lot of that when you get into hematology. So that is one common theme between a TTP that we'll do, an HUS that we'll do, and when we get to DIC on those disorders in fibrinolysis. This one, the 5 things I have bolded, any case study for TTP should have all 5. Okay? So when you're doing the case studies, pay attention to the description of the patient, because some of the 5 are listed in the description, and some of the things will be in the lab results. So remember, when you're looking at case studies, what I recommend, circle anything, like how do you know if it's autosomal or sex-linked? See what the patient is. If it's a female, you know it's not sex-linked, it's going to be autosomal. If it's a male, there's a good chance, like in hemophilia A and B, it's passed from the mother to the male. Okay? Remember, get in the habit of trying to circle or highlight what sets it apart or what is abnormal. I would recommend that on every case study, especially when you get to lab test. go through and circle what is abnormal. That way you at least key into the abnormal test. So TTP is called thrombotic thrombocytopenia purpura, and we know penia is low. And we already had idiopathic thrombocytopenia purpura. So both these, we know they have low platelets just by these terms. And we know they express superficial bleeding because that's part of the name, purpura. This one, the big difference, because if I ask you what's the difference between ITP and a TTP, there's no PAIGG. And up until this book, they didn't know, because I flagged, they're in a different chapter, HUS, and they went to chapter 34. I think I put a paper clip. They say TTP is triggered by the presence of ultra-large VWF multimers in the plasma. And that's probably the first text I've seen it not being, I'm not sure the mechanism. So they think what causes it is ultra-large VWF, and they call them multimers. They think that's what triggers the platelets clumping, and naturally if your platelets clump, they're not free-flowing in circulation, so you're going to have a low platelet count. So you have to have 5 things to prove it is TTP, and this is a big one. This is an additional one, but that is the big thing that separates it from ITP. All 3 of these diseases have low platelet count. They call it immune destruction when an antibody helps take it out of circulation. This one, it's the VWF triggers the platelets to clump together, so when you do your total platelet count, you get a lower platelet count. It is not an antibody taking it out. So you have to have 5 symptoms. First one is a hemolytic anemia. When you get to chemistry and hematology, you'll have tests that help you to know if hemolysis has taken place. You know that for a girl below 12, for a guy below 13, that is an anemia. So at least you know that much. But there are things that prove that it's a hemolytic anemia. So you're going to get to hemolytic anemias in hematology. When Barb teaches you testing in chemistry, there's a test called an LD that can show hemolysis. There's a test called a bilirubin that can show hemolysis. But at our stage, we know they have a low H&H because that we're not at a higher level yet. Okay, so hemolytic anemia. So you know it has to have a low H&H. So you should know that a girl should be under 12, a guy should be under 13 hemoglobin without me putting what normal, okay? Because we did that in hematology, MLT 150, when we did red counts and H&H and we calculated indices. So you know you're going to have a low H&H. I will give you that it has a high LD or a high Billy, because you don't know anything about those tests yet, because we haven't had chemistry. There's a test Diane will teach you about called the haptoglobin that decreases in hemolysis. So there are things you don't know yet because we haven't got to that class. But you at least know if it's an anemia, it at least should have a low H&H, and you should be able to circle that on your lab results. The next thing is thrombocytopenia. So what should you know on your lab results? What it should be less than? Less than what? 150,000, right? So on your lab results, you should see that they have a low platelet count that you could flag. One of the other things they say they have neurological problems. So this would be something that would be in the general information about the patient. They might have seizures. They might have severe headaches or migraines. They might have aphasia. Anybody know what the term aphasia means? You may not be able to speak. Okay? So, in the case study, you should look and see if there's any example of a neurological problem. The other thing they should have is a fever. So, do they have a temperature greater than 98.6? Okay, yes.
My temperature actually runs about 2 degrees cooler, and I know that there's several people that do that.
Yep, so that has to be something normal. That would be something the patient would have to give the physician in their history that, hey, I normally run 96.8 instead of 98.8, so if I have 98.6, I might have a fever. That would be something the patient would have to relay to their physician, because who would know that if you don't know that's how you run? Okay? The fifth thing is renal dysfunction. And this you've got to know, even though we haven't had your analysis yet or chemistry. There's a test called a blood urea nitrogen, and there's a test called a creatinine. Those I have to give you normals, or I have to tell you they're elevated because you haven't had a class. So creatinine, BUN, blood urea nitrogen. Creatinine is spelled like this. A lot of times we write it as C-R-E-A-T or C-R-E-A. I would have to give you the normals or tell you that they're elevated because you haven't had them in chemistry yet or your analysis yet. But before you call it TTP, you have to see the 5 symptoms, and you have to see in the writing that they did not have any PAIGG. Maybe in the test results it says PAIGG negative. In your case studies, all I can recommend is circle things that are abnormal. Okay? So these 3 are big case studies for the number disorders, because I think you're going to see these in your career more than some of the things you'll see with COAG as far as abnormal case studies. So we know platelet antibody is the key difference of ITP versus TTP. And let's see if you can remember the 5 symptoms. So there's no antibody. They say in the new textbooks they're triggered by ultra-large VWFs, causing platelets to start adhering to each other, so the platelet count drops when you do your CBC. So what are the 5 symptoms? Hemolytic anemia, low H&H at least. Thrombocytopenia, so the platelet count has to be below 150,000. You have to have some neurological abnormality like seizures, severe headaches, aphasia, something that there's neurological, but those are the common ones. It has to show a fever, and your kidney function test have to be elevated. So I either have to tell you BUN is up to 20, creatinine's up to 1.1, and you'd have to then look at the results and see if they're elevated or not. But TTP has to have those 5 symptoms before you call it.
What happens if they had 4 or 5, like they didn't have a fever?
Does HUS have some similarities? But you have to have all 5. I haven't seen a case study yet, and I make sure you have all 5. That hasn't had all 5 if they've called it TTP. Okay? Now, when we talk about hemolytic uremic syndrome, they say neurological abnormalities and the fever are not significant. I just say they're not there. Okay? Yes. Something you can't read.
Number 2.
What's that underneath hemolytic? I can't read.
LD and Billy. That's something you don't know yet, so I'm not going to expect you to know that. These I will expect you, because that's a big deal with TTP and HUS when we talk about it. But the hemolytic part, you haven't learned anything yet about hemolysis. You're going to get that in hematology with the hemolytic anemias, and then you're going to get it with liver function tests with Barb in chemistry, because she has all the chemistry tests that help show hemolysis. Okay? Most of the time, it is women between 30 and 40 years, kind of like your chronic ITP. The new book says that's the reason, the large VWF multimers. And sometimes they can try to get rid of the excess platelet clumps that are why you decrease your count by doing what is called plasmapheresis, where they can actually remove and put new in. So it's interesting, with this and HUS, they can do that. But this is a big deal, fragmented red cells. I give you the bilirubin and the LD, that is something you'll learn when you get to hematology and you get to chemistry. But both TTP, I would circle fragmented red cells. You as a tech don't want to miss that when you're doing your diff on your CBC. DIC, HUS, and TTP can have sheared red cells, and that is a big clue to the physician. So don't think, well, I already got my 100 white cells counted. Who cares about the red cell morphology? It does matter for the patient. Any one of these diseases that has the chance of clots in their circulation, there's a chance your red cells will get sheared off as they're trying to go through the circulation in your vessel. And that's a big clue the physician needs. So don't minimize doing your red cell morphology. You need to look through, and like I taught you the indices, the MCV, MCH, and MCHC, they should go with those values. There's a term Diane will teach you called poikilocytosis. That means abnormal shapes of red cells. And it goes with a term called RDW, red cell distribution width. So when I was ever doing a CBC, if I was going to see if I had problems with my red cell morphology, I looked at the RDW. And if it was elevated, you better believe I'm looking at my red cells to see if they're proper shaped or if they're sheared red cells. So you've got to learn to tie in a lot of different areas of the lab with your knowledge base. So coag affects hematology, and you'll see how hematology in someone who has mono affects serology. So a lot of the departments, I had a student who is at Sparta, and she was kind of bored when she went to Anderson for an extra week of blood bank, because she saw there they kind of just stay in their one little area, and she had to learn at Sparta. She did a couple days on heme, a couple days on chemistry, and she said she started by just making little loops. Whatever needed to be done everywhere, she would just do. So sometimes you develop your skills of putting it all together better at a smaller facility, because when you go to the big labs, you just stay in hematology, you stay in chemistry, and at Sparta, you got to learn a little bit of everything so you can be busy all day long. So sometimes you develop faster as a tech of putting it all together at a smaller facility. And she was perfect proof, because she was kind of bored because they didn't have blood bank, she just stayed put. Whereas at Sparta, if she doesn't have something, she goes back and just makes the circle and puts on what she needs. So this one, the biggest difference of ITP, there's no antibody here. They think it's attributed to the large VWFs. Those two have the antibody. So you will already eliminate TTP if you know it doesn't have an antibody. So far you have Bernard-Soulier as a case study, Glanzmann's as a case study, you have VWF as a case study, a potential storage pool disorder. If I don't have it on there, I'd add it, like aspirin. And we're going to add some more when we're done with the next piece. And then you have acute and chronic ITP, and you have TTP, okay? So tomorrow, I would really try to study a lot tomorrow, so when we review, it's valuable. At the end of class tomorrow, you'll see what you still need to study. So please don't wait till tomorrow night to study. I would really try to study tonight so our review is more valuable. I think it'll help you to see what you don't understand and you can ask better questions. I don't like giving it to you this close to a test, but that's life. I mean, we only have 2 hours of lecture a week and we can't get through it all. Okay, HUS. This is the other one that triggers platelet function, and I kind of told you a little bit about this one. Remember what bacteria and where potentially, I told you we had a case from like a young girl that had went on her honeymoon someplace. She went to Mexico and she got an E. coli. Anybody remember the bad E. coli? Your normal E. coli in your GI tract causes 80% of your UTIs. That's your normal E. coli getting into a sterile area like your urinary tract. This is a bad E. coli. It's E. coli 0157H7. You'll learn it in micro as hemorrhagic E. coli. Okay? This is the big clue. Your book talks about idiopathic or genetic and a non-idiopathic. We're just going to know the one that's affected with preceding infection. It differs. There's some similarities and differences. The similarities on HUS, it's hemolytic uremic syndrome. That uremic should give you a clue that you're going to have an elevated BUN and creatinine. So both diseases, TTP and HUS, have little platelet clumps occurring. Okay? This one, they think it's triggered by the waste products, and then the platelets start adhering to each other. So you can, it follows an infection. It's usually by E. coli 0157H7. There's another bacteria that causes GI problems called Shigella. Usually those are the two common culprits, but this is a big one. A lot of times it's in children. The case we had was a young girl. I mean, she wasn't young, but in her low 20s. So it's not always children that it affects, but most commonly they say it's children. Normally it can be self-limiting, but they're going to have similarities. Hemolytic anemia, and they could have, which I'm not going to expect you to know, the increased LD, increased Billy. That proves it's hemolysis. The low H and H, I will expect you to know. Low H and H. They're going to have increased BUN and increased creatinine. And they are higher than TTP. So let's say a TTP might be a 30 BUN if normal's up to 20. This one might be 50 to 90 BUNs. Creatinine might be 2 or 3 with TTP since normal is up to 1. In this case, it might be like someone on dialysis of 5. But these are the two similarities. The third similarity would be fragmented red cells. So when you do your CBC diff and you see the morphology, those are what are similar. There's actually no platelet antibodies, so that's another similarity. So you tell me, based on what you see up here on the board, what are differences of HUS? Okay, they both have hemolytic anemia. Oh, we know they both have decreased platelets. So thrombocytopenia. So we know they both have hemolytic anemia. We know they both have elevated problems with their kidneys, BUN and creatinine. They have fragmented red cells. They have no platelet antibody, and they have a decreased platelet count. So these are similarities. So what are differences? What do you see on TTP that HUS doesn't have? So HUS no neurological. What else does it have? Different.
No fever.
No fever. And what does HUS have that TTP doesn't have? I'm sorry, what?
E. coli.
The E. coli. So TTP has no infection that triggers it. Remember, the large VWFs trigger TTP, and the infection triggers HUS. So you need to know some similarities and differences. Both of them, what causes the fragmented red cells is there are little platelet clumps in your circulation. That's what triggers that. So platelets aren't even a cell. They're just a fragment of the cytoplasm of megakaryocyte, and they have a big role. They have a big role in disease states and your coag functioning properly. So I feel you really need to understand them because, we have potential, probably 9 case studies just from platelet problems. And they're not even a full cell. So I don't have you know much about increased. All you got to know about the reason you have a low platelet count with distribution is you have an enlarged spleen due to some cause. In the case of the lady that we had working here, hers was due to a hematological disorder that caused her spleen to start grabbing the platelets out of circulation and enlarging. So all you got to know for distribution problems, it just means you have splenomegaly, and as long as you know that's an enlarged spleen. So you don't have any case study on that. It's just what is an example of a distribution problem causing low platelet counts. And the only thing, we don't have any case studies on this, sometimes your platelet counts drop because you've had a big blood loss. So that's kind of what they mean by reactive. Sometimes if you have any kind of blood loss where maybe from a surgery you bleed extra, more than you should from a surgery, you might lose platelets, red cells, white cells because of a blood loss. So it could be following a trauma, following a surgery that you don't stop bleeding. Sometimes if they're gonna, like in the case of chronic ITP, if they are going to remove your spleen, many times and you've been suffering from a low platelet count, many times, at least for a few weeks, your spleen goes back to a normal count. So just doing a splenectomy, which is what removes all your cells, especially your dying off cells when they're going to be remade, sometimes that will increase your platelet count. But the one I want you to know for your test is an example of a disorder called essential thrombocythemia. You are born with this, and what is the clue? All your other cell lines are normal range, but your platelet counts go above 1 million. So that, the distribution where you have splenomegaly to decrease a platelet count, that is not a case study. These aren't case studies. So you just need to know an example. What is a disorder that you have very high platelet counts? And essential thrombocythemia is the one I want you to know. Polycythemia vera, that was on another slide, that increases all your cell lines. The ones I said they do a therapeutic phlebotomy where they remove a pint of blood, monthly. That increases all your cell lines, red cells, white cells, platelets. This one is strictly your platelets. That's why I wanted this one as your example. So you'll get into the myeloproliferative disorders in more detail with Diane, because that's a hematology. Most of this book is hematology. That's why I let the hematology, Diane pick it, because the bulk of the chapters, up to 30, are hematology chapters. So that's why hematology becomes the 4 credit hour class, because you got all the anemias, all the white cell problems, all the leukemias, all the myeloproliferative disorders, the ones with paraproteins, the multiple myeloma. So hematology is your first, even though this is a lot, I'm not minimizing, this is not a lot. Hematology is most of this book, okay? So, let's take a 5-minute break, because we're gonna do one more thing for your test, and we're gonna compare factor 8, factor 9, and von Willebrand's, because you already know a lot about von Willebrand's. So what you want out is this sheet I gave you. This factor 8 and factor 9 are on here, and I think they even have von Willebrand's on here. So I'll see you how you can use this. And the other thing you'll want out is in your syllabus. And I have the key already, so you won't have to worry. You'll walk out with the key. You won't have to, print it from Blackboard. But the other thing you want out is page 35. We're going to compare hemophilia A, B, and VWF, and you'll see, so we're not even going to use the PowerPoint till next week, but this will be on your test. Because it's a neat comparison chart. Just like you learned for VWF, Bernard Silier, and Glanzman, we're going to do the same thing. So we'll start at 25 till, and we're going to go through this chart, and then I'm going to tell you how I test you on the chart. I don't have you fill in the chart. I have case studies, and then I have this multiple answers correct, multiple choice that is really good of seeing if you know your stuff. That's why you got to study tonight, because you're going to need both nights studying. Because we're only going to have 2 more regular tests after this, and there's still like 8 PowerPoints left. So we'll have a lot of PowerPoints on your next 2 tests, so we got to get some of this done. Yes?
Isn't bilirubin the product of the red cells?
It's when your red cells break down. Well, Diane, you're going to go through the hemoglobin molecule and the destruction of it.
So what is the LD?
Lactate dehydrogenase, you're going to learn different enzymes that are, and it's one that's in red cells. So you're going to learn a lot of different enzymes in chemistry, and in hematology, you're going to go through what makes up the hemoglobin molecule and what happens when a red cell breaks down. And bilirubin, and we'll discuss it again when we talk about bilirubin and urobilinogen and urinalysis too. So I'll show you how it breaks down and what happens in your system. So, I think what's neat as you start getting into the second year courses, all the connections between the courses. And I think you'll start thinking, that's what they meant. You'll still start seeing how they connect. And it won't be just individual classes. You'll see how they all relate. And honestly, you guys, I am serious when I want you to beat out anybody. You want to take in everything we give you. And one of our best students for minimizing theory is now the supervisor at Memorial's new lab. And he struggled getting through the MLT BOC. And then all of a sudden the light went on and he realized, man, I got to know this stuff. Passed his MT first time, already he's almost finished his master's, and he's going to be the new head. And we are all so proud of him because he was always a great person. He always treated everybody in class right. He followed me when I was still working at St. E's, and I loved when he followed me. He'd come over, what can I do to take over for you? Let me know, because we had a half hour. Some girls, 2 of them were from our program, would say, no, I don't want to take over anything from you. You finish, and you can't finish everything. If a stat fluid comes in, it's not going to get done in a half hour from 2 to 2:30. And he was awesome. Everybody wanted to be followed by him. And he's the new lab manager. So, and I don't even think he's 30 yet. And so we are so proud that he finally, the light bulb turned on and he took it seriously, and boy did he advance. I had one other student from 2000. Her head of her lab told me she's going to be the next me, and the lab director died. She didn't wake up from a nap. She had a severe headache and she ended up bleeding into her brain. And she was only 48. And guess who became the new head? My student from 2000. And so the sky is the limit depending on what you want to do.
You said you don't work anymore at all.
I haven't worked since 2006. I did 1998 till 2006. I did every third weekend. I wanted to keep up. So I said, hey, if I can handle it, I'll do my full-time job at SWIC and I'll do every third weekend. And DJ, I know sometimes would say, oh my gosh, she hasn't been here for 3 weeks. So I started, anything we had new, I put in my drawer. I said, DJ, I won't ask you any questions till I can't follow my own notes. And it was fine. And then by Sunday, I'd say, DJ, I love doing diffs. How about I do your diffs, you do some of your maintenance, or what do you got to do for the week? So we had a great crew. And then in 2006, we went back from tri-lab to the hospital, and I would have had to take on more hours. The only part-timers, you had to work at least 40 hours in 2 weeks. And I was already doing full-time every day here. And then I would have had to add evening shifts because I couldn't work day shift. And that meant other people couldn't get a job. So one of my girlfriends. Okay, so we're going to compare 3, and these are going to be. So on your review test 3 sheet I handed out right away, you want to add hemophilia A, hemophilia B as case studies. You already have VWF as a case study. So make sure you don't leave here without writing it on there because it will be on there. We're going to compare. You already know a lot about von Willebrand's. And you probably know more than you think about these. Tell me what you already know will be the common elevated test between the 3. What factor is hemophilia A? What factor is hemophilia B, and they call it Christmas?
9.
What is missing on VWF, you already know. So the defect, if you want to put it in other, we know it's going to be factor 8, factor 9, and VWF. So tell me if you remember, how do you inherit A and B? How do you inherit von Willebrand's? And I'm okay if you just put on autosomal, you don't have to put recessive. So if I was going to give you a case study, what are your patient types most commonly going to be for hemophilia A and B? Males. And I usually give a female for my von Willebrand's because I'm trying to get you to see it's autosomal. It can be a male, von Willebrand's, but I like you to see a difference. And what you already know, the symptoms of VWF, because you already have to know them already between Bernard, Soulier. And we'll just keep it all one and the same, bleeding symptoms. What are they going to be, superficial or deep?
Superficial.
That is still the predominant bleeding for von Willebrand's, even though it can affect the PTT. It still has superficial like petechia, purpura, mucosal. But what are examples of deep bleeding for the clotting factors? When we got to secondary hemostasis, there was deep bleeding. Can you give me 2 terms? Hemarthrosis, and if everybody make sure you know that's joint bleeding. And what's the other one? The deep purple bruises, call them hematomas. Okay, so you're going to have deep bleeding. So you're not going to call it von Willebrand's if there's deep bleeding. And so we know bleeding, we'll just put deep, because I have a key with me for you already. Now, tell me what are tests that are elevated. What gets you to thinking that you have a clotting factor disorder? What test is abnormal?
PTT.
So an elevated PTT, elevated PTT. So what does VWF have for sure that's elevated or abnormal? The bleeding time is the one for sure. Depending on how severe the deficiency is of VWF, whether you'll have the elevated PTT, but for our intents, we're gonna have them both elevated. You might get cases where they don't have a very severe VWF, but that girl that we had at work, she was 18 or 19, had 1 second elevated PTT and her whole family had VWF. They just didn't have any symptoms because they'd never had anything to trigger it. Remember, this is a key difference. In your case study, look at the bleeding, look at the abnormal test. Because I have more students say it's hemophilia A and they didn't pay attention that the bleeding time was above 9 and they didn't pay attention that there was mucosal bleeding or petechiae or purpura. Pay attention to your case study, circle what's abnormal. I'm going to teach you, does anybody remember what the adsorbed factors were from test 1?
2.
There were 2 common between them. And that's something, when I tell you a key feature, you need to know them now. So this is what tells the physician, and they're not on any medication, like heparin, for instance, that can affect a PTT. So the doctor then starts thinking, you know what, they might have a factor problem or some actual problem that's genetic. There are some differences with treatment, and we're just going to have you know the main treatment. Factor VIII concentrates. Normally someone is, and when we get into, this is the main thing I want you to know for test 3, but we're going to reiterate some of this in test 4. Most of the time, hemophilia A get a vial that has multiple sources of factor VIII. That's why if the blood sources weren't now screened for HIV, you had a chance of getting HIV if you were hemophiliac, because one vial might come from 10 different people. And if you didn't have good screening, you might get HIV from just your treatment. But this is very concentrated, and it's multiple patients, factor VIII. This one, do you remember the prothrombin factors? The prothrombin group of factors that were vitamin K? 2, 7, 9, and 10. Well, they have a concentrate of those. If you're missing factor 9, a lot of times they'll give you prothrombin concentrate or prothrombin complex, PCC, and it has 2, 7, 9, and 10 in it. And anybody remember from last lecture, what's the synthetic vasopressin? It's an ADH, which is something in urinalysis we'll talk about that helps bring back water that's going to go out in your urine. It is called DDAVP, and you already had to learn this for your comparison to Bernard-Soulier and Glanzmann's. So, your abnormal test, increased PTT, increased bleeding time is the big key, increased PTT. Treatment, factor VIII concentrates. PCC, which is prothrombin complex concentrate, and it has 2, 7, 9, and 10. And then this was the synthetic vasopressin, DDAVP. So, tell me, what is the key diagnostic feature for VWF and Bernard-Soulier when we do platelet aggregation studies? What was the key thing you have to know for those two? Abnormal ristocetin.
That was for both of those?
For Bernard-Soulier has abnormal, because it needs GP1B and VWF. So abnormal ristocetin with aggregation studies. The other aggregators are normal. Well, see if you can figure out on 8 and 9 which reagent corrects them. Looking at your 2 reagents, because this will give you a precursor to substitution or mixing studies. This is something you got to know, a way the doctor could diagnose if it was factor 8 or factor 9 deficiency. Which reagent, reagent 1 or reagent 2, what we did, I could take a 1 to 2 dilution of my plasma. So let's say they suspect me of having a factor 8, no, let's say I'm a guy. They suspect me of having a factor 8 or factor 9 deficiency. My PTT is elevated, I'm not on any medication. They want a quick test to tell them if I'm deficient in 8 or 9. So they'll take 1 tube of my plasma, and so if I take 50 microliters and mix it with 50 microliters of AP, that's 1 test tube. Because it was a real easy test. They'll do 50 microliters of my plasma in a second tube with 50 microliters of AS. And they also would do a third tube, which has all factors, normal plasma. Remember, this is adsorbed plasma, this is H serum. That was in your first study guide for test 1, or in your second PowerPoint study guide for test 1. So, it was the easiest little test. So we made our 3 tubes. All we did is put 50 microliters of the patient plasma, then 50 of AP, 50 of AS, and 1 that had all the clotting factors. The first one you need to for sure run is if all the clotting factors, you mix it, you run your PTT, and all of a sudden it's between 28 and 36 seconds. You know that normal plasma provided the missing factor. So that's a big step to do normal plasma that has it all. But could you tell which factor? No, because they had all of them. So now that you know, it corrected. It made the PTT go from abnormal to 28 to 36 seconds. Tell me which of these corrects which deficiency. H serum corrects what? Which one of the 2? Which one? Because it has 9 in it, right? So under key diagnostic, you put corrected, PTT corrected with AS. So you got to know what AS has in it to know it provided that. If I do a mixture of my plasma that is missing factor 9, and I put equal amounts of an H serum in it, guess what? The H serum says, here's the 9 you are missing. Now you're going to clot between 28 and 36 seconds. It's a really cool little test. We used to do the substitution study, and it took you an extra 2 minutes just to make up your tubes, and then you were done in 5 minutes, and you could tell the doctor what factor it was. Okay, then tell me, under key diagnostic feature, which one corrects a factor 8 deficiency? I'm missing. So guess what's in adsorbed plasma? Factor 8. So under the key diagnostic feature, it corrects PTT corrected with AP. And what I mean by corrected, it brings the PTT into the normal range. So let's say my PTT was 40 seconds to start. So my first tube, to make sure it's a factor, I put equal amounts of the plasma and normal plasma. It has all the factors. So if it's a factor missing, that's going to correct to 28, 36 seconds, but does it tell you anything? No, the only thing it tells you is it's a factor. I want to know which factor. So you go to the adsorbed plasma and H serum, but we do all 3 tubes at the same time. Why waste time? You could make all your mixtures, put them all on, run a PTT, and see what corrects. Guess what it is if it doesn't correct with normal plasma? Do you need to do adsorbed plasma and H serum? If it doesn't correct, see if you can think this. Think about it. If it doesn't correct with normal plasma that has all the factors, why bother with 5 factors? This is a key step. So if you kind of get the hang of this, you're going to do fine with the substitution studies. Because normal plasma has all the factors. If my PTT is elevated and I run it with normal plasma mixed with my plasma and it still stays 40 seconds, it is not a factor. You're done. You've got to look at other reasons, and we're going to have a lecture on what are the other reasons. But in this case, for hemophilia A and hemophilia B, does everybody understand why we got to do this first? If this doesn't make the PTT go to normal range, you don't do any more. It's not a factor. Okay, and that's a big piece of the substitution study. But in our case, we know it did. So then you got to know which one it corrects with. Okay, so let's put it PTT corrects with AP. PTT corrects with AS. And we know the problem primarily with von Willebrand's is how it affects the agglutination when you use the antibiotic ristocetin. They're not worried about, are they missing some factor 8? That's a secondary thing to the VWF. So please study, because did everybody add to this test? And then we'll look at the book too, what study questions. Because look what I did on chapter 34, page 716, why I have the question marks. And I'll put this on the Elmo. We're going to do level 1, number 3. Ooh, I think it's going to be a VWF on, this is a good VWF because it even shows the factor 8 assay low and the abnormal ristocetin. So we definitely want to do 4. This is under level 1. 4, 5. We'll do 3 through 7 under level 1. Those are good. Very good. Level 2, we want 1. We'll just do 1, 2, and 5 for level 2. So let me put this on the Elmo. So you should have level 1, and this is page 716 to 717, and then is 3 through 7. Level 2 is 1, 2, and 5. And then the factor deficiencies, you have hereditary telangiectasia. Anybody remember what those had going on with them? All normal tests. Where did they actively bleed from? Lesions in their head, mouth area, nose. Bernard, Glanzman, acute, chronic, TTP, HUS, and factor 8, factor 9, and we did want to do storage pool, the aspirin effect. So you have 2, 3, and what I'll do is I'll list every possible one, and you won't have any duplicates. So at least you'll have the names listed. You just got to put them with the right case study, okay? So I'll have all 11 listed. You just put it with the right case study. Okay, and we'll practice a little tomorrow. The hardest piece, though, it's the first time I give you multiple choice that you have to have all the correct answers. So let me give you an example. We're comparing Bernard-Soulier, Glanzman's, and von Willebrand's, and I give you the multiple choice I give you, it's not a multiple choice, it's a matching, but you have all correct. I give you elevated bleeding time. What would you give me of those three? All of them, right? So you have to say A, A, BS, B, GT, C, von Willebrand's. If you only put A and B, you get it wrong. All of them have an increased bleeding time. What if I said, and you're comparing those three, an increased PTT? Only von Willebrand's, so you'd put C, von Willebrand's. If you put A and B, you get it wrong, because they don't have. What if I put autosomal recessive? All three. You have to put A, B, C. If you only put A, you get it wrong. So it's the first time you're going to get exposed to a multiple, not a multiple choice, a matching, but you got to give me all the correct answers to get it right. The one we just did, what if I said elevated bleeding time for hemophilia A, B, and von Willebrand's? What would you put? All of them, because they all have elevated PTs. Oh, sorry, elevated PTTs. You'd put all three: hemophilia A, hemophilia B, von Willebrand's. But what if I said on those three, Patricia, elevated bleeding time? You'd only put whatever letter represents von Willebrand's. What if I put intrinsic platelet defect of the first three? BS and GT. So you put A, B. If you only put A, it's wrong. So this is the first one. It'll read, you got to give me every correct choice. It's no partial credit on these. And sometimes the students, it takes them a little bit of adjustment. So please study, okay? Especially study the 11 case studies, because we'll take a good half hour to review tomorrow, and it'll be a better review if you study, okay? So please don't leave it all till tomorrow night. Okay, I know it's a lot, you guys, but let me know too when you get your other, those of you who have other finals, if there's a problem with the 12th for you. But I really think this will work great. And then we'll be done by the 12th, and you won't even have to do anything in that next week. And you'll be done. And you've done awesome in lab. We are just reviewing everything. Oh yeah, I do have it. Here, and make sure on this you put test 3. So that way you won't have to go print it, because I don't have it up yet, but you'll have it. And everybody, you know, as factor 8, factor 9, and add the storage pull aspirin effect. I think that's 6. Okay, so tomorrow we'll review your test 2. Then I have your lab sheets from last week, so we'll pass those out. We'll make sure whoever needs to do the fibrinogens first, and then we'll just put you other places that you might have to finish up. And then Thursday we'll take the test, and I'll have it all set up with what we're going to practice on Thursday. And as soon as you get done with the test, you can just go practice, and that way we might be staggered a little bit better. So we might not have as much wait time when all of us start at once. So I will see you tomorrow. So please, 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 please study.
What is the factor disorder? Is that on the study guide?
Nope, the study guide will not be on until next test, but what we did on this chart is. Yeah, I think we might be able to put it over here, because I think there might be a couple of you need the book. Yeah, so the study guide for the clotting factors I'm not putting on till next test, just the chart we just did.